From today, authorised psychiatrists are allowed to prescribe medicines containing the psychedelic substances psilocybin and MDMA for the treatment of certain medical health conditions. Well, joining me live is Professor Richard Harvey, Chair of the Psychedelic Assisted Therapy Steering Group. Professor, thank you very much for your time. And first of all, I believe there is an emphasis on a safety-first approach, and only select psychiatrists can prescribe these medications. What types of mental health conditions are able to be treated?
So what's been downscheduled by the TGA is the use of MDMA for PTSD and psilocybin for the treatment of treatment-resistant depression. But these are very much pharmacologically manufactured substances. They're not the sort of MDMA that people might be aware of on the street, and it's not psilocybin that will be coming from, in inverted commas, magic mushrooms.
Well, that's a very important message, isn't it, Professor? Because we have heard stories of people perhaps taking recreational drugs and it not being what you're talking about here. So a very important message. And again, certain psychiatrists can prescribe this. It's very early days, though, I believe.
That's right. So we have been somewhat taken by surprise by the decision to make this downscheduling so quickly. So the College of Psychiatrists, we made 2 submissions to the TGA where we really said this is too early. There wasn't enough data at this point, but nevertheless, the decision has been taken that that there was, I think, based on the concern about there not being other effective treatments for this group of patients. I think the other important message is that this is the use of these substances as part of what's called psychedelic assisted therapy, which is an intensive and extremely intensive type of psychotherapy that lasts for around 40 hours and involves 2 trained therapists working with the patient, going through some preparation sessions, then going into what are called dosing sessions. And patients may well only receive 1, 2, or possibly 3 doses of the psychedelic substance in a hospital or hospital-like environment, a healthcare environment with a medical practitioner present, and then have 8 hours after that dosing session with the 2 therapists. And that's really quite unprecedented for psychiatry, that we would spend 8 hours with another therapist working with one individual patient. And then there are what are called integration sessions, when the patient comes back and continues to work with the therapists on exploring, unpacking, and resolving the experiences within the dosing session. So it's, the psychedelic substance is a small part of this. Really, it is the therapy that probably is doing the work in terms of helping people recover from their illnesses.
And Professor, how much do you estimate this to cost for a patient?
Well, that's a good question. We don't know at this point because there is so little evidence and no evidence of cost benefit. These are not treatments that are currently funded, so there's no Medicare funding other than minimal funding for the therapist time. We don't know whether private health insurers will fund this. And just a broad estimate, knowing that the substances have to be imported from overseas, they have to be managed within a pharmacy system, and just the amount of time required from the psychiatrist and the therapists, estimates are somewhere between sort of $15,000 and $25,000 for a course of treatment, with probably almost nothing back from any other source of funding.
And again, Professor, we talk about it being early days, you require funding. And in terms of a patient, how much rigorous assessment do they need to go through to actually get the go-ahead for this treatment?
Well, these would be patients with existing conditions. So they would be, PTSD is a very unpleasant condition with very disabling symptoms, and also, unfortunately, is quite common in the community. So, these are patients who would already be under the care of a psychiatrist. Same thing with treatment-resistant depression. Having a type of depression that doesn't respond to other treatments is very unpleasant. So these are people who are already under or should be under the care of a psychiatrist. And it's really up to that psychiatrist to discuss with the patient whether referring you for this type of treatment would be the right thing to do. Other points to make would really be the authorized psychiatrist, so the psychiatrist who's going to provide the substance has to gather together a team. has to source the substances from overseas, has to put all of those proposals to an ethics committee, who then approves what will happen. They then take that ethics approval to the TGA, and the TGA look at what their proposals are and then issue the authorised prescriber status. And then within each state and territory, the prescribing psychiatrist would have to apply for a permit to treat the specific patient with that substance in a particular location. So there's, if anything, the amount of work that it places on the psychiatrist who's prescribing is quite considerable.
And Professor, we hear other treatments such as ketamine, again with the patient and psychiatrist, and with the product. You're the expert. You could tell the audience much more than I would know. But in terms of this type of therapy, do you see this moving more forward in the future?
I guess we are keen to find any effective treatments. Hopefully, and part of our recommendations and guidelines is that comprehensive data needs to be collected as part of these treatments, including extended follow-up treatment. So we are aware of some signals from ketamine trials that when the ketamine treatment ends, patients can return quite quickly, quite suicidal. So part of our recommendation is the same for this treatment, is that beyond just the course of treatment, patients must be very carefully followed up to make sure that there are not some late adverse events occurring that we need very much to be aware of. But if we can prove these treatments work, then yes, they would be a real paradigm shift to how we practice psychiatry and could offer some promise. But the data isn't quite there at this point. But we do have this new down scheduling that just makes it slightly easier for, researchers and clinicians to implement these treatments.
All right. Well, we really appreciate your time and expertise, Professor Richard Harvey, and we look forward to hearing more. Thank you very much.